Welcome, everyone. I'm Emanuele D'Angelantonio, author of the paper entitled Classification-Based Screening of Phlebopathic Patients Using Smart Socks. This project was born within Technoscience, a research center in Rome, and it is developed through the collaboration with Roma University and with the University of Rome for Italico. And naturally, I would like to thank all the authors who have collaborated in this project. In the following presentation, I will introduce the project, describing its context and its goal. We'll talk about materials and methods used to realize the classification system that will be described. At the end of the presentation, the results will be shown with a little discussion about them and with the presentation of possible future developments. World Health Organization defines the telemedicine as a delivery of healthcare services where patients and providers are separated by distance. It is an important research field in which technologies play a fundamental role. In fact, wearable sensors and telecommunications networks are crucial elements for the telemedicine and for the telemonitoring system's achievements. Most of telemonitoring systems available concern the monitoring of vital parameters, as for example, the heart rate, blood pressure, temperature, for a control of general well-being. But telemonitoring is for sure highly relevant in assisting patients suffering from chronic diseases, as phlebopathic disease and so chronic venous disease and diabetes. Phlebopathic diseases involve the blood vessels and generally develop and worsen with age, causing swelling in legs, itching, pain, and in more severe cases, deformities and ulcers. They are very common in the world, with 30% of male and 55% of female affected in Western countries. They have a very strong impact on the quality of life of people, and also due to their chronicity, these pathologies cause huge expenses for the healthcare system. As an example, only venous disease costs are estimated around 1–2% of European countries' budgets. For these reasons, it is important to prevent phlebopathic pathologies, and it is crucial to continuously monitor patients in order to avoid the onset of complications. So telemonitoring systems play an important role in remote assistance, with the possibility of a continuous patient monitoring outside the clinical facilities, naturally, controlling and preventing pathological complications with a significant reduction of resources and costs for healthcare system. In the paper, we propose a novel technique for remotely screening between two groups of participants, patients suffering from phlebopathic disease and healthy subjects. The screening is based on machine learning assisted gait classification. The proposed framework is shown here in this slide, where first a patient with a wearable device is subjected to an experimental protocol, then collected data is analyzed with software and with machine learning techniques in order to identify signals ascribable to the disease. Finally, the classification output is then sent to the physician for telemonitoring through a web platform, allowing visualization of data over time. In this context, our main contribution consists in a feasibility study allowing the creation of a machine learning model that is the core of the proposed framework. In this context, in the context of pathological gait classification, many works utilize machine learning techniques, and this table summarizes some related works, dividing them by examining disease, instrumentation used, and the adopted machine learning techniques. The last column shows the ratio between healthy and pathologic population, and it is possible to observe that in many works, this ratio is really unbalanced. Here, the two graphs better represent the instrumentation and the machine learning architectures used in the literature works. From instrumentation graph, it is possible to observe a balance between laboratory tools and wearable systems, while in the graph on the right, we can notice that the most used machine learning techniques are the k-nearest neighbor, support vector machine, and artificial neural networks. In this work, we developed support vector machine and k-nearest neighbors models. The materials used are the data acquired by the Sensoria socks, Commercial socks represent the year in the figure. They have got 3 taxi pressure sensors positioned at first and fifth metatarsal head and under the heel, and a 9-axis IMO that is positioned few centimeters over the malleolus. Data acquired by the sensorized socks have been elaborated with 2 software. The first one is MATLAB with its specific application classification learner that allows to create and train classification models already implemented in it, while the second software is Weka, an open source software entirely dedicated to the machine learning. To develop the screening tool, a feasibility study has been conducted on a population of 42 participants composed by 21 subjects, healthy subjects, and 21 pathological patients. The measurements of the participants suffering from chronic venous disease were made in Pierangeli Hospital at Pescara, while a healthy control group performed the test in the University Research Laboratory. In the table, there are the anthropometric information of the entire population divided into healthy and pathological. The tests carried out by the population sample are 2, an orthostatic test and a dynamic time up and go test. For the aims of this study, only the dynamic time up and go test was considered, and it is described in literature as a clinical model for balance and mobility assessment, and has been chosen because it evaluates different motor skills to maximize the differences between healthy subjects and patients. How it is possible to see in the figure below in this slide, it is composed by 5 different phases that are the sit to stand, walking forward, turning, return walking, and stand to sit phases. To have an idea of the data acquired by the two populations, and in order to make a first qualitative comparison between a healthy and pathological trace, the graph represents the normalized pressure signals coming from 2 subjects of our population. The one above is that of a healthy subject with a normal gait, while the one below represents a pathologic gait. It is possible to observe qualitatively the differences of the traces, with the normal gait much more regular than the one below. The data acquired by the SOCs were processed using MATLAB through the following stages: organization and data processing, task segmentation and parameters extraction, future metrics, and classification. Firstly, data acquired from SOCs were stored in cloud and then saved in local, organizing and collecting all the trials in a 6-dimensional matrix. This matrix contains all the acquired data with a reduced dimension of only 9 MB, a fundamental aspect for telemonitoring systems. After that, the trials were automatically segmented into the tag test phases using a combination of pressure and IMO signals. In the two images below, an example of the tag phases detection is shown, representing a pressure signal used to determine the sit to stand phase, and on the right, the longitudinal axis gyroscope signal used to find the turning and the stand to sit phases that are characterized by turning movements. Once done the segmentation, the code follows with the extraction of parameters that will be used in the classification. The first parameters extracted are spatiotemporal parameters. They have been calculated from the individuation of the steps done by the subject during the straight walking, both in forward and backward walking. In the graphs that are the 2 sample signals referring to the right foot trial of a subject during his forward walking phase. The peaks detection has been used to count the number of steps from which other parameters are obtained. All the spatiotemporal parameters, in fact, extracted are reported here in the table, where their mean and standard deviation are shown. In addition to the previous spatiotemporal parameters, also some pressure parameters were added. They were extracted from digital signals provided by the SOC's pressure sensors under the foot sole, as shown here in the figure. We included the only available uncalibrated values as adequate description of 6 selected features that are the mean of pressure peaks of each sensor, naturally, and their reciprocal ratio. Once extracted the features, a preliminary classification approach has been done. The entire population dataset was used to train and validate different classification models into two different environments, MATLAB and Weka, in order to have a comparison between them. From the accuracies obtained in this preliminary approach and from literature evidence, we selected two model families as best models that are k-nearest neighbor and support vector machine. The performance of different models of these architectures was evaluated using in both software the 5-fold and 10-fold cross-validation techniques in order to test and stress the models. The validation accuracies obtained in the two software are quite similar, and an example is shown in the two tables reported here in this slide. The best performance was obtained using the weighted KNN and linear support vector machine. In this slide, the flow chart shows the process of training and testing of these two specific models. The dataset was randomly divided into two distinct subsets, constituting the trained population and the test population. The first one is composed by 32 subjects, while the second one by 10 subjects, 5 healthy and 5 phlebopathic. The use of different subset for training and testing is fundamental for having a true test for the realized models. In fact, in this way, the classifier never saw the subject of test population. The tested model results are evaluated in terms of these specific parameters, accuracy, precision recall, specificity, and F1 score, all obtained from the confusion matrix organized as shown here in the table. The classification results of the two tested models are shown. On the left, there are the confusion matrices, while on the right, there is a histogram graph which compares their performances. In the confusion matrices, we can observe that on the main diagonal, there are the trials correctly classified, while on the other diagonal, there are the not correctly classified ones. The good results of both models are evident, in particular of the linear SBM. In the histogram graph on the right, we can notice that the models have accuracies above 85%, a recall that goes from 90% to 96.7%, and an F1 score above 85.7%. In conclusion, we can assert that this work enabled the creation of a framework for screening and early detection of patients suffering from vascular diseases, starting from signals collected through SOCs with sensors. Various supervised classification models were created and compared, combining spatiotemporal parameters typical of gait analysis with features extracted from plantar pressure. I'd like to focus on the good classification results obtained with the two tested models, and in particular way, I'm talking about the linear SBM model that gets very good performance, better than the KNN. The SBM, in fact, shows an accuracy of 91.7%, an F1 score of 92.1%, and a recall equal to 96.7%. These results are lined up with several works in literature, in spite of our relatively simple measurement system. In fact, in literature, it is possible to find works with accuracy higher than 85%, reaching in some cases results around 97%, but they regard other pathologies, and above all, they use laboratory tools or far more complex measurement systems. In addition, in many works, in many studies, the ratio between healthy and pathological participants is often very imbalanced, and these can alter the results. The future developments of this work are various. Our first one regards the test of all the validation procedures, like the leave-one-out subject cross-validation technique, in order to have other data on the robustness of the developed models. Of fundamental importance is naturally the possibility of defining and using new parameters for the classification, also extracting them from tag rotational phases, not investigated in its work. This can lead to better classification performance and to the ability of refining classification, increasing the number of the investigated classes with the possibility to distinguish patients according to the severity of their disease. For this goal, we plan to acquire data from the population during medical therapy and in the domestic environment. And this is the base for regression model development. That is a second stage of the project for a predictive medicine application. Following this path, The system could be integrated also with other wearable devices, as for example an IMU belt or a sensorized t-shirt. The classification and regression outputs could be analyzed for a correlation with clinical scales used by doctors in the treatment of these pathologies. And last but not least, other developments regarding the implementation of the classification system in web platform for the optimization of web service. In conclusion, once again, thanks to the team that collaborated for the realization of this work. And naturally, thanks for your attention.